group, would look to both join that and become a customer, if you will, and maybe even think about kind of the questions that we'd want to pose that we might be able to start to think about in terms of getting some data out of the system that we would be useful to our implementation of a children's behavioral health plan. So that's number one. Number two, as Jeff said, we're pivoting today to really discuss some of the outcome measures, some of the data elements that we might look at from a variety of sources in order to be sure that we could say that the children's behavioral health system is successful, improving, and that we have ways of measuring that, and that we would come to some kind of agreements around those. So, so I appreciate everybody's joining and look forward to a good discussion. So thanks, Jeff.
Sure, thanks, Tim. So I'm going to pull up a screen share, the Excel spreadsheet that I sent around a couple of weeks ago now. And I just want to start, before we dive into this, I had a few points I wanted to make just to kind of level set. First of all, this spreadsheet is not intended at all to be the data collection that's going to occur. And this data collection can be one of those topics that gets people a little anxious and nervous. Well, like, I can't believe you're going to ask us to collect all this. The point here is we wanted to try to get a number of indicators at the individual system level. Some of these things are pretty loosely connected to behavioral health, it might seem. But the idea here was, let's just get a lot of information out there. Let's start to generate some good thinking. There will certainly be some things here that are totally irrelevant, but there's likely also going to be a number of things that are missing from the spreadsheet. So we want to get your best thinking as you take a look at this about what's missing, you know, what's extraneous and we don't need, et cetera, et cetera. So that's kind of point number one. Point number two is just really putting a finer point on what Tim just said. The idea here is that we want to identify measures at the systems level. How will we know that our behavioral health system as a whole is working? What kinds of indicators and outcomes do we need to look at for our system? Just drawing a distinction between what we may want to know about whether services are working for an individual child and family. So just kind of keep that in mind as we go through this list. The third point I wanted to make is what people used to call, we want to try to get the Cadillac version. Well, I have started now referring to it as the Tesla version, or pick your luxury vehicle. But what we want to do here is we want to identify ideally, what kind of measures would we have? Not necessarily what do we have or what's easy for us to get, but what information would we really want to have ideally to know that our behavioral health system is working. Also, as we go through this, I just ask that you kind of pay attention to this column on source, because what you might find is that, oh, it seems like I really like a lot of measures from Inc., or I seem to really like a lot of measures from CMS's behavioral health core measure set. That's actually useful information for us too, because it might mean that we can kind of lift from one set of measures primarily and work with 2 or 3 sources or something along those lines. So try to pay attention to source as well as we go through. I know it's a little hard to do because there's a lot of information in that column. And then finally, the last point I wanted to make is I'm sure that there's going to be some discussion about the logistics of collecting this information, and I think that's important. But the main point for today's conversation, at least, would be to just try to focus on what measures would we want to see, not necessarily who's going to collect it, where is it going to be collected, when is it going to be collected, is it going to integrate with my EHR? Those are all really important things that we are going to want to talk about and need to talk about. But if we can today just kind of focus on the measures, I think that would be useful. So if for those of you who didn't get a chance to kind of get the lay of the land on this spreadsheet, I tried to organize it according to individual level behavioral health and well-being measures, and that includes both mental health and substance use measures that are collected primarily at the individual caregiver or sometimes the family level. There's a whole block here of behavioral health system measures that come from a variety of sources. So these might be ones that we look at and say, you know, that kind of hits the mark in terms of system level indicators that we would be interested in having access to in Connecticut. And then I also created blocks of similar measures, a number of those related to school measures, a number of measures related to physical health, social determinants, and involvement in other systems. There's a whole lot of those. Not all of them are going to be useful perhaps for us, but they're in there nonetheless. So that's kind of how the spreadsheet is organized. And if you have it in front of you and can open it up on your desktop as we go through, that might be helpful. I probably won't be able to project the entire spreadsheet at one time. So I'm going to stop talking and just open up the floor to anybody who wants to jump in and start discussing.
I guess my initial impression related to the measures are that the behavioral health system measures seem to reflect more as to whether the children's behavioral health system is, doing well. And, it would seem that a lot of those kind of cross-cut across many different programs. So for example, the ED, inpatient and outpatient utilization rates would seem to be more relevant.
Mm-hmm. Okay, great. Thanks, Kathy. I might just kind of like put an X next to things that people mention that they like a lot. If two people say it, I'll put a second X, so just something that I might try to do just to organize feedback here. Any other thoughts? Chris, I see you're off mute.
So I just have one thought too. I don't know if this would be helpful, but I'm thinking of a possible framework to be able to see, so like the triple aim for if we want to look at multiple different measures, if we want to be looking at outcomes, quality, and cost, I think it would be helpful to have some type of framework to help organize our thinking and then identify which measures could go into which buckets of a framework as well. I think that may be helpful to kind of just help organize our thinking, because I think depending upon our perspective, we may be really focused in on education outcomes. But if we want to look at the entire system, I think we need to have some type of broader framework to help organize our thinking. One idea.
Yeah, really good point. Really good point. I think as I look at these measures, some of them are access related, some of them are related to quality. Many of them are just sort of utilization focused. Very little on cost in this set at least, but if you're aware of other data sets that have good metrics and measures related to cost, I think that's would be helpful to hear as well. Thanks, Chris. Other thoughts? Are there measures here or metrics that you just love and say we have to have this?
Jeff, I wonder if it might be helpful to just focus on one section at a time. I don't, just go through it and then just behavioral health, the mental health and substance use and the well-being measures maybe is top of the list, and then go from there.
Okay. So let's do that. Let's start here. We'll start with this block right here. And that block is separated out because they're identified as individual child or family level or caregiver level measures, as opposed to these system level measures down below, which we'll get to next. But as you look at this set, and what jumps out at you as good, bad, or otherwise?
So the second comment I would make, maybe for people to think about, because with data, it's always easy to make an argument about why we should keep something in, but I think maybe we should be thinking about what maybe we should get rid of. I was just thinking, like, there seems to be a lot of things here that would be nice to know, but a lot of it could be kind of at an individual level versus as a systems level. So, do we really need everything that's there? So that would be what I'd be looking for people's feedback about.
And it seems like there's also some duplication between kind of the system measures and the individual well-being measures. So for example, emergency department visits for substance use and you have the ED utilization rates.
Yeah, good point.
So I guess I'm having a hard time. I have a question more than an answer here, but what do we mean by the children's behavioral health system functioning across a high performing functioning system? What does that mean and what does that look like? I think being able to define that, I think would be helpful to then be able to identify what are the key measures or metrics that fit into that definition.
Yeah, it's a good question. I would actually go back to your first comment, Chris, and suggest that that the two comments you made, one about a framework and one of the question you just asked, are pretty closely related to each other. So just as a jumping off point, I would say that that your behavioral health system is working if children and families have access to it, if the services that are being delivered are high quality, if they are resulting in the kinds of outcomes that you want to see. And again, I'm distinguishing between reduction in problem behaviors as an individual outcome measure versus total number of ED admissions in a given time period, for example, as an outcome, as a system level outcome. And then fourthly, your suggestion around cost. Not necessarily that we're reducing costs. That's something that Bill Halsey talked about in one of our other meetings, is that we shouldn't presume that the system, we should always be looking to save money. But I do think that we should be looking to have a system that's working in a cost efficient manner and saving dollars when we can, for example. So ED and inpatient admissions is a good example. They're very expensive services, and when it's not the appropriate level care, that's money spent for one service that could be spent more efficiently in another service, for example. So I would just offer that framework as a way for thinking about whether the system is working: access, quality, outcomes, and costs.
Yeah, and Jeff, I propose maybe for the next meeting, we'll have this broken down in that kind of category. So I wonder if it might make sense to focus on quality and outcomes for this conversation, and then we could broaden it. If somebody comes across access or costs, I think we could throw that out there. But I think we started out thinking about the quality and the outcomes indicators. So
okay.
Yeah, so it sounds like if you are going to look at these metrics, you would look at them through the lens as to which one would indicate a high quality system, right? And
Right.
which one would indicate high outcomes.
Sure. Yeah, I agree. So maybe that's something that we can, as I'm typing this out right here, as you identify measures, maybe as we go through this, we can say whether we think it's an access, quality, outcome, or cost measure. And like Tim said, maybe focusing more on quality and outcomes, since that's mostly what we have, and some access indicators. So as we go through, let's just start with this block again. As you look at this list, what jumps off the page for you as being, that's potentially a good indicator of quality or outcomes?
I mean, personally, for just speaking for myself, I think the two that stick out here in that framework are, I would say, we constantly hear in the literature about ED visits. I think ED visits are always just constantly in the news, and you hear a lot about that, especially for youth. And then readmission rates. I think those two really stick out. Hospital readmission rates. I think those two stick out as the most.
Great, thank you.
I would add also, hi everybody, I'm Jennifer Jenks. I'm probably the newest person to Connecticut Behavioral Health, and I come from Rhode Island, where the last 9 years I ran a busy emergency service for Lifespan Healthcare. So I'm very, very interested in collecting data. We looked quite a bit at EMS runs by diagnosis code to see if it was an appropriate need for that resource as well. So just to add on to the emergency department use or misuse, I would add also EMS runs.
EMS runs, meaning just,
Each time they're
is that-
called. Yeah, each time they're called, they call it a run.
I'm going to add that as under just provisionally under the system measures. And thank you for that. So
I know in Rhode Island, the schools often call 911 or get an ambulance to transport a child versus, I'm not sure if that's as big an issue here, but I'm already seeing it at the Children's Center that ambulances get called quite often.
well, I can assure you, as a former Rhode Island person new to Connecticut, it is an issue here in Connecticut as well. I think as it is in every state. So we hear and talk a lot about the number of kids who are transported one way or another to the emergency department, and many of whom may not need to be there and could be better served in a community. So yeah, that is definitely a lens that we look at our system through as well. So we'll go back up to this list here. Anything else that people want to flag as potentially being, really worthwhile? I would personally have a significant concern about students who have seriously considered or attempted suicide. It's an individual measure, but I think if there were a way to collect that kind of information at a population level, I think that's a pretty significant indicator about whether we're identifying kids who are showing signs of depression, anxiety, or other conditions that may ultimately lead to feelings or attempts at suicide. So that to me is something that we should be paying some attention to as well.
Yeah, I agree, Jeff. I think it's interesting that it's not under the system wide, that there's no kind of metric around suicide screening, positive suicide screening at the system-wide level.
Well, let's add one, Kathy.
That jumps out at me big time.
Yeah.
Yeah, part of that, I think maybe, one of the goals of the Suicide Advisory Board is to get universal screening for suicide across all behavioral health. And if we were successful at that, then we could in fact
Exactly.
using that, so that those two go hand in hand. I think this really comes from the student risk survey, risk health survey.
And is that listed on here under school measures? Didn't look like it to me.
No, most of those are, as mostly like educationally related measures.
Yeah. Okay. Because there are many school systems doing those, student risk surveys at this point in time.
Can I ask a quick question on the first 2 points here? Students who do not feel safe and who do not feel loved and supported. Should there be questions about who feel that they need, would be better served with access to these types of services? And have they had trouble accessing services? I'm unfamiliar with this work. I freely admit that.
Yeah, I think are measures that you can see they're collected as part of the Connecticut Kids Scorecard. I wish I could tell you, and if somebody knows the answer, please jump in. But I believe that may be something that's administered at the school level, at least sampled at the school level, and then reported out on sort of a population level. So I don't know if to your question, I don't know if there are additional questions on that measure that get to whether those same individuals feel like they have access to the behavioral health system. In fact, I would say that this measure set we have on this Excel spreadsheet is a little weak or limited on access measures. So that's something we would really want to, that's something that we could flag as an important point, that we would need to identify some really high level, high quality access measures to add to this set.
Okay, that sounds good.
Yeah, I think we know, that's been one of the longstanding issues, that we don't have a good gauge on access across the system historically.
So just let me just add to that a bit. Something I've had over the last few months, I had some conversations with probably some of you, thinking about looking at if we could comprehensively look at wait lists across the system of care. So if we knew that there were long wait lists at the outpatient level, for example, or if we knew that there were long wait lists and intermediate or intensive in-home service level, for example. That to me is a pretty, if we could systematically collect that information, that would be a pretty good system indicator as to whether our current capacity meets demand for services. So I would propose that could be a pretty important access measure that we could, if we could find a way to systematically collect it, could be really useful information for us to track.
So that's been a challenge for DCF for quite some time. We actually have some data elements that often are unused, and our sense from the provider community is, and folks here can let me know if I'm on the mark, but our sense was that when you're on the wait list, you're not actually engaged, and therefore you don't take time to enter it into your data system because you're not fully in treatment. And then if you in fact go ahead and do so, then the question is, are you now legally obligated because you're now connected? You have a quote unquote note in your electronic health record or however you open. Are you engaged in treatment when you're not? Legally, are you engaged in treatment? So it's a dance that we know we have had a challenge with the provider community on that. And again, our desire is not around that legal issue. Our desire was, again, to try to figure out access. But so it's always a challenge. And most of the time, we get a sense from the managers of the different service categories about that. So we'll have free conversations about that and kind of monitor on any given time of the year, you know, what generally wait lists are like across different service types. So
Yeah, I think more of the issue is related to that topic, Tim, is that number one, kind of the work it takes to kind of log all that data. But secondly, you have families that are on multiple wait lists for multiple levels of care, because it's kind of like, we know which one they need, but if the wait list is too long, you know, their current provider just kind of puts them in everywhere. And so then you have the duplication. So it brings up that question as to how accurate the data is.
yeah.
But it is a fair amount of work. You know, for CHR as a system, we get, you know, hundreds of calls daily requesting services, and we do log them all into our EHR as a kind of a referral status. So we know that. But it's, again, looking at how accurate the data is. And until you have the ability to track kids kind of across the state and look at kind of where they might be on the wait list, that would be a challenge. So.
Right. And we know families will call for places just to get on all of them and see who calls first. So, you know,
Exactly.
there's a lot of challenges with access, Jeff. That's what I mean, that historically we have not, until you get that single unique identifier kind of system where we're all connected and, you know, the gold standard as we're looking at. So.
Okay, other comments on this block before we move on to the next section?
From a strengths perspective, I'd really like to be able to have some kind of data collection around the resiliency piece and the protective factors. I really think that there are indicators of so much as far as chronic mental illness and chronic substance abuse that I really think that it would behoove us to collect data on that.
Yeah, very good point. I'm glad you raised that. There was this recommendation that came out of a pediatric primary care work group, as well as the health enhancement communities, to collect protective factors and resiliency. So I went ahead and flagged that one as something that's definitely worth collecting, so that we're getting at strengths and not just deficits-based measures.
And we can maybe potentially look to the work of the PACE project to see if, because I think they're looking at a bunch of those positive measures too. So.
Great, thanks. Okay, Kathy, go ahead, please.
Sorry. You know, I'm just thinking about kind of how you evaluate what the need is across your behavioral health, you know, across the system. And so I suppose you can get into some of that with the protective factors and the resiliency, you know, looking at suicide screening. But, you know, how do you really know what the needs for the youth in your communities are? Unless you're doing some universal screening of some sort in order to assess that. So I don't know how to do it, and I don't know if it's really reflected here. I see a consumer assessment of healthcare providers and system survey. I don't know if that gets to it, but kind of getting into a needs assessment, I think should be integrated.
Yeah, it's a great point. I'll just flag it here. Consider universal screening to determine need.
Yeah, that's something that I was thinking of as well. So as a provider of services, it would be great if we could get to a state of providing services based on need, right? The demand. If we have a set number of clinicians, we could move towards substance abuse, or we could move towards particular types of treatment that would be most helpful to our communities.
Great. Okay. Any other comments, questions?
Are we collecting any data for crisis intervention services? I haven't seen.
We have, I think there were a few crisis related items.
There was a mental health crisis services I can see here, but through the crisis line and intervention, how many calls we receive, and they're all get engaged or help. So that is also an important factor.
Well, and I think
So
I think it's data that we have readily good access to too.
Yeah.
Through
Yeah.
the youth mobile crisis. Yeah.
Yeah, I mean, at least as something that approximates it. I mean, we could obviously easily collect that information on number of calls that come into our mobile crisis line at 211 requesting mobile crisis
Right,
intervention.
221, correct.
Yeah, so we definitely have that, and I think it could be, one way at approximating need. And I think it strikes me as something that's a little bit like ED visits in some ways too, right? If you are getting a lot of calls there, you may be approximating need, but I think that's also data demonstrating that children are showing up in these places in crisis often, which means that they're not accessing services at an earlier point before it reaches a crisis situation. So, but yeah, I think just for now, I put it here under universal
Yeah.
screening or determining need, and I think crisis calls could be one of those indicators. So thank you for that.
Right. Okay, thank you.
We'll have a very good source. So right now in planning for the 988 system that's across the lifespan, we're working through with United Way to develop an integrated dashboard across the lifespan and multiple doors into the crisis call system. So it's not just mobile crisis, and it's not just calls, it's calls, text, chat, who could come in from the national lifeline and could come through the information and referral. There's not a lot, but some even sneak through there. So what United Way is doing is creating dashboards of integration across all the different avenues, and that will be across the lifespan, but then we could peel away the child side of that. So there'll be good data there.
Thank you. And one more thing I haven't seen here, how are we collecting data of the health equity purposes, like inequities?
Yeah, it's a good point. I think what I would suggest is I think it fits nicely into the framework conversation we had at the beginning. We look at needs, access, quality, and outcomes. I think we should be looking at all that from a equity lens.
Equity point of view. Right.
So thank you for that. I think that's a really important point too. So
Jeff,
looking at chat box, Tim, go ahead.
It just made me think of another comment on that last point is we are considering behavioral health, but we also know that there's a significant co-occurrence with like the top 3 to 5 medical issues with a high degree of behavioral health. And we probably can get that, like I know obesity is one, so those kinds of,
In integration.
Yeah, maybe a handful of the medical integration.
Okay, so I'm going to put that here and put it as a new item, put it in orange. So consider physical health comorbidities, comorbid with behavioral health conditions. Great. Okay, so as we're moving on here, let's take a look at this next set. We've already started to get into some of these, obviously. We already identified ED utilization rates, inpatient utilization rates, and outpatient utilization rates as being measures that we should be paying attention to. I think there's kind of a combination, I think, of system outcome as well as maybe access. So I'll just kind of flag them
I
as
think it's both.
originally, yeah. Okay, so anybody else have thoughts about anything they see on this list?
Do we know what the definition of treatment penetration is?
I don't actually. I kind of got that. I have this list as kind of a list of indicators without much of like a data dictionary behind each one. But my guess is, it could be what I would like to think it is. I guess I'll just say that is that among a population that are known to be in need of services, what percentage or actually receives services. So it kind of gets back to what we were talking before. If you can determine the actual population or number of children who are in need of services, and then if you had information on how many of them actually accessed services, that would give you a treatment penetration rate. And again, that's just me speculating or hoping that that's what this means. But by all means, kind of jump in and tell us what you think would be helpful there.
If that is what it is, I think it would be great. Like how many start treatment and how many actually follow through.
The treatment.
That actually speaks to the comment in the chat about canceled appointments and do not shows as well, and keeping track of those for clients who sign up for treatment and then don't actually come.
No show rate.
Yeah. Okay. So.
Yeah, but I think in order to effectively look at no-show rate, you'd need to have a baseline as to what, based on the population, what you would expect. And we'd have to look at kind of national levels with that compared to Connecticut levels.
Yeah, I was going to say that earlier. A lot of this, I mean, some of our baseline work across the system could just based off of populations, prevalence rates, et cetera. I mean, that doesn't do us good for specific parts of the state or where high needs are, but it gives us a starting point, at least in a number of areas.
I think following up with that, to be able to trace that with race and gender and ethnicity is going to be significant to really identify our underserved populations and marginalized populations.
Yeah, and then the barriers like transportation services and all.
Yeah, we have hints of, this question about access keeps in the back of my mind, because again, how do you get at it? But if you look at our
barriers,
you look at our data, a lot of the in-home mobile crisis and other in-home, you see a broader diversity than those who get in. And so you could suggest that getting in creates barriers for some community, some families, depending on where those services are provided in the community. So access, there's definitely challenges around that related to race and ethnicity and locations, zip codes.
This is Elizabeth. I wrote something in the chat, but I don't think, Tim, I don't know if I don't want to bring us back if this was discussed, because I hadn't been in an earlier meeting, but I noticed that we're not including like grant funded data system, DCPI or the CSSD system. But part of what we're talking about here seems to me that if we could track how many who get referred get connected. And so I wonder if there are ways that we can collect comparison of rates of referral to who gets connected to services, because that's where a lot of families get lost and then show up in other later on in the system that we tried to prevent. So I don't know if the systems that are high refers to behavioral health services like school, DCF, the courts, if there would be a way to, if they have that kind of data. I think some of our programs do have that data in Pi.
Yeah. So again, so I think that ultimately, I think we're still looking at indicators in general. And Jeff started with this handful of data sources as just a kind of a jumping off point. So data sources, one of the biggest challenges after we say we had this list set today is then, well, what are the sources to collect that data and to be sure it's across the entire system versus one small narrow group of the system. So those are going to be some of the follow-up challenges. But it's why the conversation earlier around universal screening or suicidal screening for suicidality, those are hugely helpful steps because it gets everybody kind of in a universal jumping off point, if you will, and we could go from there. But yeah, so your point is very well taken, Elizabeth.
Well, I think two things. One is looking at those data sets because we had good ideas, at some point that data sets were developed in Pi and the CSSC system. But I'm just thinking about, I think an important indicator is something to capture referral and connection.
Yeah.
And again, I think that data is going to be skewed to some degree because of the comment somebody made earlier about, probation officers and DCF workers throwing out 8 referrals, seeing where they're going to land first, or families pursuing multiple avenues simultaneously. So there's got to be some way to be able to differentiate that, I think.
Yeah, so one possible area of solution, and it's not an entire solution, but it's one of the biggest challenges right now. So the example I often use is every kid in the system, behavioral health system, wherever they are, goes to school. But very few referrals into the system come directly from schools, minus mobile crisis. Mobile crisis is one of the biggest ones. So in the school-based mental health arena, the student mental health arena that we've been working on in the AWARE with CHDI and Department of Ed, is helping schools identify student mental health need. And if you can imagine, if we're successful at that, and it would have to be a universal success, essentially what you have is the possibility of students who are in school who have a mental health need. If schools were the location where, if they only just knew the connectivity where they were, then you can bypass, was that student on 4 or 5 waiting lists, kind of thing. What you just know is they're connected and here's where they're connected. So it's a possibility, but it's a ways off.
Yeah, you'd really need that unique identifier for the individual in order to see where they landed, in order to really know if the referral kind of panned out with them getting attached to a level of care. Because right now we just have the data per each level of care, which doesn't tell the full story.
It does, I think, making a broader point here around identification and screening rates. So there's a few in this block having to do with screening. And I think one way of thinking about whether our system is working well is knowing that just to throw out 2 examples, that schools and pediatricians are screening for behavioral health. I mean, that is something that I think is really important to a well-functioning system. So I happen to like a few of these. There's a few of these up here. So for example, trauma screening in primary care is one of the SHIP measures. I happen to like that one. It doesn't necessarily have to be specific to trauma. It could be just screening for behavioral health. I know there's a Medicaid code for pediatricians to get paid for screening for behavioral health. So that's something that's out there. It's being collected and something that we could track and monitor as being just an indicator of whether our system is functioning the way it should. And I would add the level or degree of the degree to which schools are screening and referring to treatment as well.
The and referring part is what we're not capturing. So like the screening is really important. And so then, because we have some data at a national level, so 20% of those screened in a pediatric setting might meet the criteria for would benefit from behavioral health services. But how many, how many are screened, but also how many get referred would be, but I don't know how to capture that, but that seems like an important thing. Where we're screening, do we refer?
Right. It's a very good point.
Tim, one of the reasons why I was trying to set up a meeting with you is in our project, when COVID first broke out in Rhode Island, we were using the Unite Us platform, an EReferral platform. And we got all of the school systems around the state to try and use that EReferral platform for just this type of data. I know Connecticut's very different in terms of how the behavioral health system functions, but that particular software drives some really very relevant and exciting data. So for this, it might be helpful for the schools.
Yes, and we still need to have that conversation.
we will circle back.
Yes, thank you. Jeff, on another note, I think we haven't made any comment at all about it, but we really should talk about it, particularly where we are right now, but adequate and diverse workforce.
Yeah, I was just about to go there. I was just about to go there. Yeah, I'm glad you raised it, because I would add it to Chris's great suggestion around a framework, that some indicators that kind of group around the workforce area, I think would be a smart thing for us to do, because we may be able to identify need, we may have services available, but we may not have the workforce that necessary to address the need. And that's something that we're hearing from providers through these work groups. So,
and we could probably just throw a couple quick notes. Total number, adequate numbers of workforce, well prepared and ongoing kind of competency development kind of, and then diversified. Those are the areas that we would want to be sure about.
Say those for me again.
Total numbers, quality, just ongoing competency development, and then diversity.
Right.
And then you get into the, evidence-based piece of it also, that the, provision of services is evidence-based.
Yeah, so that one, I was just about to highlight that one. So thank you. I'm looking at this one right here. I think it's a good indicator of quality. And we don't have very many of those on this list kind of identified as good quality measures, but that's an important one. Great.
Just wanted to kind of reiterate a point, or kind of go back to the larger framework idea too, is that when looking at the total system impact throughout whatever metrics we decide to choose, I do think that we should be not only looking through a health equity lens, but also social determinants of health lens, and also social deprivation, because we know those factors also impact outcomes, quality, and access, right? So I think that we need to keep that in mind, not only just looking at a straight measuring of whatever metrics we select, we need to be adjusting for, or being able to take into account for, health equity, social determinants of health, and social deprivation. I think those factors really, we have to tease apart those and actually include that into whatever model that we're thinking about as well.
Yes, and when we get to that, we'll circle back to you, Chris, because I know you have a little bit of experience with that. Thank you, Chris. That was helpful.
Sure.
Great. Okay. So any others from this list? I also happen to like this one here. Organizations adopting class standards. There are a number of you probably on the call who have participated in class work, which refers to culturally and linguistically appropriate services. I think it's another good kind of indicator of workforce or system functioning to know whether provider organizations are working toward a national standards around cultural and linguistic competence. So I'm just going to go ahead and flag that one, because I got the screen. So there it is. And I think this one, Tim pointed it out already, but we'll just kind of mark those as well, since we log them down below. Okay, so we have about 10 minutes left. Anything Chris, you talked about social determinants. If anybody wants to jump in and talk about any of the school measures, please jump in and do that. But for now, why don't I just ask Chris to tell us just a little bit more about social determinants and social deprivation indicators, and where we might be able to access those.
I mean, one of the biggest ones that we're exploring right now is it's called the ADI. I think it's the Area Deprivation Index. And so this is a measure that looks at zip code and the relative impact of the 9-digit zip code on certain outcomes. And so I think that is more of an adjustment factor rather than a particular outcome. So I think it's something that we should take into account when looking at these metrics. We need to take into account the ADI, the Area Deprivation Index. So that's focused in on income, social deprivation within the zip code, as well as can take into account food insecurity. So I think that measure can also be used as an adjustment factor.
So I hopefully that note captures it well enough, Chris, and we can look more into it.
Sure.
Great.
Jeff, do we want to spend, did anybody, I mean, looking at the sources, we didn't spend a lot of time, but you pulled together, were there any major data sources that people think of that we might have missed or might want to look at?
Well, I know DCF has just made a significant move to starting to incorporate the expert evaluations into their substance abuse screenings and treatment modules. And so if we're going to start looking at access and follow through with referrals to actual treatment, we might want to be able to take a look, especially since primary care is going to be the primary source for the experts of how many are administered versus how many are actually admitted to treatment.
Great.
But it's a whole pool of data that's going to be accessible.
Thank you.
You also mentioned PI, but the CDCS is the judicial branch version of PI.
Right. I wonder if that, just when you bring up expert, whether, we have the Children's Behavioral Health Plan Implementation Advisory Board, developed that inventory of screening tools. But I wonder if that would be something, since we've identified tools that are important for identifying children's behavioral health need.
Yeah, I thought about that earlier, Elizabeth, and I was going to say something, and we just, so it's a great resource for us and the work of this group in its largest context. And if we, again, can get back to promoting some of those screening tools in Connecticut and across the system, that helps us regardless of the data source.
Yeah, because if we could track, I mean, those are the kind of outcomes we would want to see, with, both for detection, but even for system improvement. If we're using those tools, wherever we're using them, try to track them in broad stroke.
Mm. Good.
And early childhood indicators there would be important. Let's make sure we're capturing those. I mean, in our optimal system, that would be something we'd be wanting to emphasize, is that we're screening early on and connecting parents to resources in a pediatric context.
Yeah, good point.
And tracking how we do with that.
I'm thinking about Help Me Grow and the Child Development Info Line, because I know they collect some information.
The ages and stages screening measure, yeah.
Yeah.
Two additional thoughts on sources too, Jeff. I think you mentioned one was about costs. Under AHRQ, there's the HCUP project. It's the Healthcare Utilization Project. They specifically focus in on some healthcare cost and utilization metrics. So that may be a source that we would want to look into a little bit more. That's under AHRQ. And then I do believe that SAMHSA also has an annual behavioral health survey there may be some SAMHSA related metrics in that survey that we could adopt or take on. They look at kind of the state of the nation on behavioral health, but I believe there may be some metrics that we could identify in there as well. So just 2 additional sources possibly.
Did I got the H cup through AHRQ?
Yep.
What was the other? It was a SAMHSA measure.
SAMHSA annual survey on behavioral health. I believe they have an annual survey out, and they do have a host of different metrics within that annual survey. Maybe there's something in there that we could also look into to see if there's any other additional metrics that we don't currently capture.
Got it. Thank you.
And then lastly, this group put a lot of effort in kind of coordinating and working across multiple state departments, particularly with OPM on data integration. But if anybody is aware of, and Chris, I think Beacon has done a little bit of work in this area that we're working on, but if there are other areas that are looking at other projects that are looking at the quality of the children's behavioral health system or the behavioral health system on the lifespan, because that probably would also be helpful to us. If you could just let us know, because we'd like to coordinate any other efforts that might be occurring, or at least work jointly again to try to be sure that we're not creating more fragmentation or silos, or creating inconsistencies when we could be very consistent.
Great. Okay, everyone. An hour goes by quickly. So thank you again for being part of this. I think we got a lot of really helpful, useful information. We kind of validated a few things that are already on this list, but we also came up with a number of additional ideas as well as sources of data that we want to look into. So we will continue to kind of work with this. Tim, do you want to say a word at all about future directions for this work group before we close it out?
Yeah, I think what one of the things we really want to do, we want to finalize kind of a formal recommendation around the P20 WIN project as a starting point for us. That's our priority. And then when we kind of finalize this activity, or again, I'm not sure it will ever be completely finalized, but at least have some recommendations around this infrastructure that of talking about measuring the system. So those areas that we've outlined with Chris's help on the quality outcomes, et cetera, access, costs, workforce, that structure. And when we then have what we feel is a decent kind of grouping, we can also pass that along. So, but I think our major point of work is to, again, try to support, join, and endorse the integration work, the data integration infrastructure development under the OPM and P20 WIN. So that's really the main component of this, and we'll continue this conversation. And these outcomes also have interests in the other work groups too, and some crossover. So we'll make sure that the other work groups are aware when we get to the kind of that point. So appreciate everybody's continual involvement. So that's my comment, Jeff.
All right, thanks, Tim. Thank you again, everybody. What we've been starting to do is we're getting a lot of actually good information in all of our work groups that are going into the chat box, and we get to most of them, but not all of them. So what we're doing is we're copying and pasting everything that goes into the chat box, except for people's like, hi, good mornings. We're putting those right into the minutes at the end of the minutes, just so that we have documentation of the good information that's coming in through the chat box. As you go out through the course of the day, your week, before we meet next, if you come across a great source of information or data and you want to just shoot me off an email, hey, Jeff, have you seen this? We might want to take a look at that. By all means, send me an email. I'd love to look at anything that you think may be helpful for our purpose of this group. And we will see you again. Tim or Leah, do we have a sense of when our next meeting date is? I don't have it right in front of me.
Yes,
Actually, I do actually.
It's
September 22.
Yeah.
All right, great. So
September 22nd.
We will see you all again on September 22, if not sooner. Thanks again, everyone.
All right. Thanks, everybody. Bye-bye.
Bye.
Take care.